We have the project manager in the person of Dr. Kwabena Opoku-Mensah. He is a research fellow with the School of Public Health, Department of Social and Behavioral Sciences. His research interest spans adolescent health and resilience. So please, ladies and gentlemen, let's welcome Dr. Kwabena Opoku-Mensah as he gives us an overview of the SIHI project activities.
Thank you, Madam Chair. Permit me to remove my mask for now. Thank you all for coming. We are grateful that you are here to listen to us. Just a brief background on SIHI project and what we've been doing since we joined the global network. SIHI is Social Innovation in Health Initiative, and it's a global network that was launched in the Philippines in 2014 to bring out together individuals, organizations that have passion for social innovations in health, just to improve healthcare delivery and also health research. And it conducts public crowdsourcing to identify innovations that are otherwise not known. So the activity of SIHI is to identify innovations out there and then provide the necessary platform for these innovations to be showcased. Next. The Department of Social and Behavioral Sciences, SOFS, at the School of Public Health, joined the global network in April 2020, that's last year, through a joint proposal with its counterparts at the University of Makerere University in the Uganda, and then Nnamdi Azikiwe University in Nigeria, that's the Schools of Public Health, for that matter. So our regional secretariat is at the Makerere University, the School of Medicine, the College of Medicine in Uganda. As part of our activities, our main objectives of SIHI-Ghana is to institutionalize public health as well as delivery of care in Ghana and in West Africa. We're talking about innovations that have been done in the delivery of public health in the country as well as extended to West Africa. And we are also aimed at developing a curriculum for innovations in health to be taught in our school and possibly extended to our sister institutions. We are also aiming at creating a critical mass of SIHI advocates, especially through the training of our students and also people that we deal with as implementers in the field. Our approach is that we are identifying and researching into innovations. We are developing and connecting innovations to the various platforms so that they can also be heard and they'll be given the necessary support. Currently, we are also supporting and guiding innovations that have been identified to model them so that we can scale up. Our activities mainly involve identification calls that we put out there to enable people who are innovative and are operating to come on board so that they come and showcase their innovations. We're also modeling social innovations, as I mentioned earlier on, through mentorship, so that we nurture them and then expand by way of coverage in order to benefit our people. We are also developing partnerships with sister institutions, implementers, and state and non-state agencies so we can move forward. Now, we receive a lot of support from the university since we set up last year, particularly from individual faculties, from the public affairs directorate, and then from the various departments that we normally deal with. And we are grateful to these people. Currently, we are developing partnership and collaborations with the TGR, especially the Africa Regional Training Center, which is hosted at the School of Public Health. So we are fortunate to have that training center there. That's also giving us the necessary support. We are also in touch and working with UNICEF through one of its major projects called the Communication for Development, that's C4D in short. And we are grateful for their support. The Ghana Health Service, through the various units and departments, is also supporting us. We have NGOs in health and also identifiable individuals, including students, who are actually, we are going to help to develop interest in research and innovations. Moreover, we've done a lot of contacts with our colleagues in sister universities in Ghana, and we hope that they also take up the issue and join hands with us in order to move forward. Now, a few things that we've managed to do, even though as young as we are, we decided not to crawl, but to walk and run. So immediately, we started our sensitization sections, or as one of the first steps to introduce the project or the program to the university community through one-on-one contacts with faculty and members, senior administrators, meeting with SPH faculty as a school to discuss the way forward. And this thing was done in June 2000. We've also been reaching out to other colleagues in other departments and schools and institutes within the university to come on board and identify some of their students who may be interested in. Now, apart from the UG community, we've also been doing national sensitization, and we've done this through non-governmental departments and institutions. We are also contacting people through our social media handles, such as Facebook, Twitter, and also we are using group contact. And then the bigger CR platform, that's the global platform. So we are out there on the globe seeking for assistance and then seeking for the necessary support that any entity might wish to launch our maiden call. And that call was limited to the university, members of the university community only. Received 13 submissions. And after in-house review of the submissions, we forwarded 11 out of the expertise in health brought together to review the proposals that were submitted. And some of the submissions that came. Now, out of the 4 that came, the initial call, case studies on these 2 sites, and these case studies have actually featured in the SIHI Global newsletter that was published in June 2001. So those 2 innovations that we visited so far, they are out there globally. It was supposed to be a 1-month duration, but for the election, the euphoria that came during and after the election, we needed to extend the period for the call. And so we extended reviewers. And out of these 9, 3 were selected. So in total, SIHI-Ghana has recognized 7 innovations within this short time, which we are given the opportunity to announce themselves and also present themselves to the world for any assistance that might come. Now, one may ask, why are we calling for people to come? Opportunity to give recognition to these innovations. Because many a times, people are doing a lot in their communities, but they are hardly heard. And we are providing the platform for that to be done. Now, we are documenting innovations and showcase them on both local platform and also on our global platform. So we are giving the opportunity for you to reach out there. We are also sharing and then networking with you, the innovators, and then with our partners. We have a lot of funding agencies out there for the global level, and we believe that when your innovations are well read and understood, some of them may come on board and reach out to you. We are also learning through the various workshops, and so we will be invited to come on board to participate in some of these workshops as part of your capacity building. So these are some of the benefits that our innovators are going to get But lastly, let me say that you also be called upon to join in our training sessions, either as a facilitator, based on your expertise, your area of research, and your interest. And also, you may also be invited to come as a participant to be trained in other spheres of your innovations. Publications. As a child of a research institution like University of Ghana, SIHI-Ghana cannot do but also join in the publication of the university. And so initially, the two of analyzation and then the full story of those case studies will be put out there. Now, we are also going to publish the videos that we've done so far on some of the case studies. The videos are currently is to encourage students, as many as possible, to develop interest and research into social innovations so that we do a paradigm shift of doing the usual thing that we know and rather go out there, study innovations going on, and see how we can put those innovations into perspective in terms of the theories and then the practices that we are known as researchers. We are also in touch with our collaborators, and we want to expand our spheres and reach out to other institutions. Ultimately, we will develop a curriculum, as I mentioned earlier on, in social innovation in health initiative studies in the School of Public Health. And lastly but not the least, we want to extend a hand of collaboration to all of you, innovators, students, and then the media to join us in this effort of bringing healthcare to the doorstep of our people and also researching into healthcare. With this, I would like to thank you for coming and then thank you for listening. And I want to end by saying that two of the innovations that you'll be listening today is coming from students' research that is impacting on the health of people out there. So when you sit in, you realize that your research that you do is really going to make impact if you take it beyond just earning the certificate. Thank you.
Thank you, Dr. Kwabena Opoku-Mensah, Project Manager for SIHI-Ghana. There are other members of the project team that I would like to introduce. But before that, I would like to acknowledge the presence of Dr. Patricia Akwengo, the Head of Department, Health Policy Planning and Management, School of Public Health. Doc, you're welcome. Thank you. So before I go on to the next program, I would like to also introduce to you the SIHI team for Ghana. To start with, the project team members. First is Dr. Phyllis Dako-Jeke. Please, if she's around, she could kindly come forward. I'd like to introduce them to you. Dr. Phyllis Dako-Jeke is a senior lecturer and the head of department for the Social and Behavioral Sciences, School of Public Health, College of Health Sciences. She has extensive research experience in the provision of extension services in areas of relevancy to public health. Dr. Dako-Jeke is the country lead for the SIHI-Ghana Hub. Please, ladies and gentlemen, let's welcome Dr. Phyllis Dako-Jeke. She's here. Second is the project manager that we all know, is Dr. Kwabena Opoku-Mensah. I have already introduced him, so Dr. Kwabena Opoku-Mensah, could you please join Dr. Dako-Jeke? Third, also a member of the team, is Dr. Emmanuel Asampong, a senior lecturer in the Department of Social and Behavioral Sciences, also a trained clinical psychologist with immense experience in teaching, research, and service. He is also a member of the SIHI-Ghana Hub. Please, a round of applause for Dr. Emmanuel Asampong. And then we have Dr. Philip Tegnefa Tagbong. Dr. Tagbong is also a lecturer in the Department of Social and Behavioral Sciences, School of Public Health. He's a registered nurse by training and has a PhD in public health. He's also a member of the SIHI-Ghana team. So please, ladies and gentlemen, For today's program, the SIHI-Ghana team members are before you. Please, anytime you see them and you have your innovations, you can accost any of them with the innovations. Thank you very much. Please do not go. We are almost coming to the end of the first part. It is the launch of the national SIHI project. So I call on the chairperson, Professor Mavis Dakujeke. Professor Mavis Dakujeke to officially launch the SIHI projects in Ghana. Madam Chairperson, please. Please, a round of applause for Madam Chairperson.
Thank you very much. I think we have heard few things, like insights into what SIHI is all about. We'll say that those are the teasers. We are sitting back to listen to what is in there that we can't wait. But at this point in time, we have to launch it before we go into details. So I would say that I declare that SIHI is officially launched in Ghana. Thank you.
Thank you, Madam Chairperson. So, like the project manager said, we didn't crawl, we started running. So now that we have officially been given the permission to sprint, we would also let other members know what we are doing. Again, we are streaming live on YouTube and then Facebook, and we have other members joining us online for this program. I would also want to acknowledge Dr. Jojo Menyo. He's the head of department for Biological, Occupational, and Environmental Health Sciences of the School of Public Health, College of Health Sciences, University of Ghana. So Dr. Jojo Menyo, please, you're welcome, and thank you for coming. Ladies and gentlemen, we've come to the end of the first part of the program. Okay, so a few acknowledgements also. We also have Joanna Anson of WHO here. Please, if you're here or online, if you're here. Okay, thank you. Thank you for joining us. And Madam Charity Eniku. Charity, thank you also for joining us. You're very warmly welcome, and we are grateful for your support. So we have to break for now and then take pictures, the second part of the program. We are going to have presentations in the second part, 5 presentations in total after each, and they'll follow and answers. Please, I expect that we ask a lot of questions to our innovators or our presenters who give us their presentation so that we get a better understanding. The whole purpose of this is to get to understand what is going on out. Ladies and gentlemen, I once again thank you very much for joining us for this first part. I'm definitely sure that you will join us also for the second part so that you listen to the innovations that we have for you. Thank you once again, and let's break for the pictures. Thank you. So the photographers, please, where do we? Outside. Okay, please, ladies and gentlemen, you could kindly let us by the lawn. It's a very nice place. We can take the pictures so that we show them. Thank you very much. And our colleagues online, thank you also. Thank you, Prof. Hello? Yes. Please, may I have your attention? We just have a 10 minutes break. So a 10 minutes break. A few announcements. The washroom is just out there, a bit far away. You could see the administrative team out there. They would help you and show you where it is. So if you need to use it, you use it. Please, our innovators and presenters, be getting ready. Immediately after 10 minutes, we start with our presentations. And for this session, the high table will join us here at the audience so that they can also see the presentation. So please get your presentations ready, and we will start in 10 minutes. So we are on break for 10 minutes. Ladies and gentlemen, our 10 minutes break is up. Please, if you are outside, kindly join us. We are about to start the second session of the program. Thank you very much. So, as earlier has been indicated, this part of the program, we have our innovators, 5 in all, giving us presentations on varied areas of research. So the first presentation will be on mHealth, strategy to increase access to cervical cancer screening in the Ghana East municipality. The second presentation will be on using SMS and VDOT to monitor adherence among women with tuberculosis and TB with HIV. The third presentation will be on Mind It Ghana, the use of mHealth strategy to increase access to mental health screening and management. The first will be done by Dr. Adana Nwameme. The second will be done by Mrs. Caroline Baji. The third will be done by Dr. Lati Dede Achu. And the fourth, which is on community scorecard to improve accountability and governance of community-based health planning and services strategy, will be done by Mr. Samuel Maiden. The fifth, but not the last, will be done by community engagement strategy to sensitize and screen people on hepatitis B and C, and this will be presented by Mr. Wisdom Pusiga. So each presenter is allowed a maximum of 15 minutes, and then after the presentation, after the total presentation, the 5 presentations, we would have question and answers and suggestions from members of the audience. So please, the first presenter, like I said, is Dr. Adana Nwameme. She is a medical practitioner by training. She has a Master of Public Health in Social and Behavioral Sciences from the School of Public Health, University of Ghana. She also has a PhD in Public Health, also from the School of Public Health, College of Health Sciences, University of Ghana. Dr. Nwameme's research areas spans gender, maternal health, health-seeking behavior, and others. She has years of experience in doing research and practicing also research. So please, ladies and gentlemen, if we are ready, and our media people and our crew, let's welcome Dr. Adana Nwameme. Please, with a round of applause.
Madam Chairperson, Professor Dakojeke, Professor Aziato, ladies and gentlemen, good morning. My name is Dr. Adana Nwameme, and I'll be making this presentation on mHealth strategy to increase access to cervical cancer screening, and it was done in the Ghana East Municipal. So with regards to cervical cancer, annually, almost 500,000 women worldwide come down with that disease, and 274,000 of these women die. Of this number that die, 80% of them live in the developing countries. Back here in Ghana, we have 67% of women who are diagnosed with cervical cancer dying from the disease. So the higher rates of cervical cancer and the mortality that we have in sub-Saharan African countries has been attributed to some factors, and these factors include poor access to timely screening that these women need, and then also poor access to treatment of precancerous lesions. So with the research that we did, our intention was to look at an alternative way to the conventional pap smear that is at the healthcare facilities. So we have the pap smear that is the conventional way of doing the screening for cervical cancer. And then the problem is that the pap smear is unavailable to women living in many sub-Saharan African countries. So this is due to shortage of the pathology specialists that need to do the pap smear and also look at the cells look at the pathological cells. And then there's a lack of financing and then unreliable laboratories in sub-Saharan African countries. So using the visual inspection with acetic acid is an alternative to the pap smear, being that it is a cheaper alternative and also much easier to carry out because you don't need laboratories to do the VIA. Here in Ghana in 2005, the first national policy for cervical cancer screening was established. And this policy recommended that women who are between the ages of 25 to 45 should be screened with VIA. And then anybody that has precancerous lesions should be treated. This service hasn't really been accessible to many women in the country due to the lack of integration of the screening into the primary healthcare system. And also the fact that there is a shortage of health care workers who know how to who have the skill set necessary to carry out the screening. So for this research, what we did was take 15 CHOs and train them at Kodebu Teaching Hospital over a 2-week period. And they were trained to carry out the visual inspection with acetic acid and use that in conjunction with cervicography. The cervicography entailed taking pictures of the cervix of the women that were being screened, and then the goal of the whole training was to ensure that the access to cervical screening is improved in primary healthcare settings. So this will ensure that women who are far away from centers that have the testing like Reach Hospital and Kodebu Teaching Hospital can have that service brought closer home to them. So at the initial stage, the nurses had a 3-month guided review where they did the VIAs and then took pictures of the cervix. And then they had an expert reviewer who was able to collaborate with them, look at the pictures that they've taken, and give them feedback over the first 3 months. Following that first 3 months, then they had 6-month follow-up without feedback, but still exchanging those pictures with the expert reviewer. So the CHO's diagnosis skills were compared with that of the expert reviewer. And at the end of the 6 months, the agreement rate between what the CHOs have diagnosed and what the expert reviewer has also come up with based on the pictures that she was sent were measured and compared. This innovation is affordable to the women in peri-urban areas and in areas that are far removed from the centers that are that already have the screening facilities like Reed Hospital and like Kodebu Teaching Hospital, in that the CHOs that are trained to carry out the screening are already within the communities. And so it makes the screening services more accessible to the women at the primary healthcare level. Also, the fact that the screening centers were set up in the communities where the women live also ensure that the women do not have to travel too far away to go and access the service. So with the VIA and cervicography, as of yesterday, it can be done at cities, and at Kodebu, it is being done at 150 Ghana cities. So looking at the reduction in price for the VIA and the reduction in transportation costs, this VIA with cervicography at primary healthcare centers reduces the cost for the women and also makes it more affordable to them. So by way of achievement, we were able to train 15 CHOs and then screen 169 women over the 12-month period of the program. The total agreement rate between the reviewer and the CHO's pictures was 95%. For the positive cases, we had a 61.5% agreement rate, and this was mainly due to the fact that this lower rate, mainly due to the fact that we have fewer positive cases. And then for the negative cases, we had a 98% agreement rate. So this high agreement rate for negative cases would help to decrease the number of women who go for referrals for treatment, or who would need further evaluation and will have to be sent to referral centers for that evaluation. And all of this will decrease the burden that the Ghana health system will feel from having to deal with the number of women that have to come to the referral centers for either treatment or for further evaluation. We had also had about 13 women, representing 7.7% of the total that were screened, who tested positive for pre-cancerous lesions. And for these women, we offered them cryotherapy treatment at the centers in their communities. One woman had a suspected cancer case, and she was referred to another center for further management. At the end of the research, we had in-depth interviews with both the CHOs and the women who partook in the screening, and they were able to tell us that for the CHOs, they were able to tell us that during the time that we carry out those screenings amongst the women, the training was good, because this particular CHO that makes this comment says that she was able to screen 3 to 4 people per day during the training. Interviewing the community women who also partook in the screening, they also process itself enabled them to understand what the cancer was and the need for the screening in their communities. It was embedded into the already existing CHIPS program in the communities. So, being that the CHIPS program in Ghana is functional in many parts of the country, it's possible to feed cervical cancer screening into the program at the different districts and at the different difficult to reach. And then furthermore, the CHOs had the opportunity during their usual health home visits to talk to the women about up in the communities. So having the centers that are within reach of the women to be screened enable the women to be with the CHIPS program and with the CHOs that live in amongst them. It has the potential to enable sustainability of this exercise. Some of the challenges that came up had to do with convincing women to allow the nurses to take pictures of the cervix. But with proper health education in the communities before the exercise began, we took the CHOs into the communities, let them talk to the women over time, educate them on the need for the screening, also educate them on the fact that a picture of your cervix still leaves you as an anonymous individual. So over time, the women became confident in the process and allowed the cervicography to go on. The other challenge that this research could face with maybe piloting and scaling up will have to do with funding, because training the CHOs and setting up the satellite screening centers are there are financial considerations to those issues. But the service has the potential to be self-sustaining and can also generate funds for itself if the clients can pay in part or in full for the procedures. And then having the NHIS also do some coverage will be advantageous to the exercise. So in going forward, implementing this strategy in other settings in Ghana and piloting it will enable more successful results from it, lead to discussions about incorporating it into the CHIPS policy, so that if we can get it to be embedded into our primary healthcare settings, then there will be more women who can be reached with this screening service, and then we can save more lives of women in the country. Thank you.
Thank you very much, Dr. Adana Nwameme. Please, we could do better for her. The next presentation, which we will also have for 15 minutes, is going to be done by Mrs. Caroline Badji, and it will be on using SMS and VDOT to monitor adherence among women with tuberculosis and then TB and HIV. Mrs. Badji is a nurse with several years of both quantitative and qualitative research experience. She recently has completed a PhD in public health program from the University of Ghana School of Public Health, College of Health Sciences. She is currently an assistant lecturer with the School of Nursing and Midwifery, also with the College of Health Sciences, University of Ghana. Please, ladies and gentlemen, let's welcome our second presenter, Mrs. Caroline Badji.
Hello, everyone. Madam Chairperson and all other protocols observed. I'm presenting on using mobile technology for monitoring tuberculosis treatment among women with tuberculosis in the Greater Accra region. To not let you wonder what the VDOT and SMS are, anytime I mention SMS, I'm referring to reminder messages that are delivered to people on a daily basis to remind them to take their medicines. And the VDOT is a video version of the current mode of treatment for tuberculosis, where instead of the patient going to the facility to be observed taking their medicine, they sit in the comfort of their rooms and just video themselves and then send the video to the nurses when they are done. Tuberculosis has for years been a great public health importance. It's been over 6 decades since the first TB medicine was discovered. Yet, challenges with non-adherence to TB treatment remains with us, and this has resulted in new strains of the disease developing, and these strains are very expensive and difficult to treat. So in 2019, there were 10 million TB cases recorded globally, with women accounting for a third of it, and those who were co-infected with HIV also accounting for over 8% of that number. Mobile phones elsewhere have been used and suggested to be a very cost-effective way of monitoring adherence, people's adherence to their treatment. So this study used mobile phone as a possible strategy to fight the challenge of non-adherence to TB treatment. The problem at stake is that females usually suffer severe form of TB, and research suggests that they are unable to adhere to treatment due to their gendered roles. So the efforts to contain the TB challenges, coupled with the fact that women who are most affected, having been much studied, was what led to this study. Although several other authors have used the SMS and the video and recommended that it is very feasible in our context and is very cheap to use, very little has been done about it in our context. And also, there is evidence that majority of Ghanaians, over 85% of them, have regular access to personal mobile phones. So the study used mobile phones as a possible strategy to monitor TB treatment adherence among women in the Greater Accra region. The intervention being discussed here are 2. The first one is a one-way SMS reminder. And these messages were developed from a formative research using 3 facilities. So in-depth interview was conducted among women who were receiving treatment for tuberculosis in one health facility to generate messages that they would like to receive as reminders. And these messages were then pre-tested among women who were also receiving TB treatment in 2 other facilities. So based on their input, the messages were fine-tuned and put in a message library for the main study. And the SMS intervention was implemented among 230 women. They were divided into 2 groups, where we had 105 in the intervention and then 125 in the control. So those who were recruited into the intervention group received daily reminders to take their drugs. And before they were recruited, we measured the baseline adherence rate for all of them. And then when they finished treatment, we measured the baseline adherence for all of them again, so we could compare the effectiveness of our intervention. And then the second intervention, which was the VDOT, was a video app which was developed for the study by SIHI-Ghana Limited. They developed the app, and unlike other apps that had been used in Kenya, which required the patient to have someone hold your phone and video you whilst taking your drug, this app, which was developed for the study, was self-sufficient in that the patient could video herself taking her medicine without anybody supporting them. So with this selfie mode of the video, they uploaded it onto Play Store. So wherever you are, you could download on your phone, and then anytime you click on the app, it opens up and you video yourself. But what happened was that we didn't implement this intervention. We only showed the participants how it functions, how they found it, and then we interviewed them on their acceptability of such an intervention in our context. So at the end of implementing the intervention, the baseline adherence rate, which was measured for all participants, regardless of the group to which you belong, you notice from the table projected that the baseline adherence for all participants was close to 58%. However, when they all completed treatment and we measured adherence rate among all of them again, I'm referring to the total at the bottom, the baseline adherence increased to a little over 65%. Now we compare the adherence among the intervention and then the control group. And then you observe that at the baseline, the intervention group had an adherence rate which was slightly lower than those in the control group, 57 versus a little over 58. But when they completed treatment and we measured their adherence again, you observe that those in the control, their adherence rate decreased to 51.5, whereas those in the intervention had the adherence rate shooting up all the way to close to 81%. And we compared their characteristics to ensure they were similar. So one demographic characteristic, which was income, which was significant among them, we controlled for it, and still the adherence rate was significantly higher among the intervention group as compared to the control group. When it came to the VDOT, the use of VDOT in our context, close to about half of them had willingness to submit videos for monitoring. Only about a third were willing to submit videos of themselves taking their medicines to their nurses. And the various reasons that they gave all boiled down to the fact that they didn't trust the internet and the social media platform. And they were scared information about them might leak in ways that they never expected. For the affordability of such an intervention, the bulk messaging platform, which was used to deliver the messages to all the women, was quite cheap. A message to a participant at the time of the research was less than 3 pesos to deliver a message to one participant per day. And elsewhere, the VDOT has been shown to actually save cost of TB treatment by over 50%. And the platform provides a very good lead for a cost-effective intervention in our context to monitor people's adherence to treatment, considering the fact that a huge percentage of Ghanaians have their personal mobile phone, regardless of their location, whether they are in rural or urban area. And this was revealed in the study, where we had 85.6% of the study participants having their personal mobile phone. And even the about 14% that didn't have their personal mobile phone, they had regular access to the use of other people's phone on a daily basis. The intervention is highly scalable in that the tool that is needed to implement it is very popular across everywhere. And in developing countries like this, like Ghana, where we still have high coverage of mobile phone, it is very easy to implement such an intervention here. For the sustainability, it was observed that none of their background, the background of the study participant, none of their backgrounds influence the effects of the SMS reminder messages on their ability to adhere to treatment. So regardless of the type of individuals or participants, it is very easy to sustain such an intervention among them. And this, in the long term, will eliminate barriers where patients have to travel to their nurses to be monitored, or nurses have to be trained to go out there to monitor, or get a personal monitor for them to ensure they take their drugs. And this goes a long way to reduce the financial burden which the End TB strategy seems to achieve. The few challenges that we encountered implementing this intervention was network issues, but this was very minimal in that we scheduled the messages to be delivered at 6 a.m. every morning. So we check at 7, and then you notice that a few hadn't been delivered and they have to be resent. So to avert that, we got someone who regularly monitored the platform to ensure that messages that failed were resent to the individuals. The way forward is to disseminate this finding, like I'm doing to you here today, to as many stakeholders as possible so they could take it up. And this, we observed, may not only be for TB. From our interactions with nurses and then patients, some were co-infected. And then they tell you, I wish I could receive a reminder for this, my drug I take at this time too. And then some ask you why you won't reach my cousin who is not in Accra and is here. Why don't you do some among them? We are hoping that funding will come our way, and then we scale this up to other areas of Ghana and possibly cover as wider area as we did for our research. Thank you very much.
Thank you very much, Mrs. Baji, for your presentation. So the third presentation, also 15 minutes. Please, I'm hoping you are noting down your questions for all our innovators. Also 15 minutes will be on Mindate Ghana, use of M-Health strategy to increase access to mental health screening and management. This will also be done by Dr. Lati Dede Achu. So Dr. Lati is currently a house officer at the Holy Family Hospital in Koko. He attended Presbyterian Boys Senior Secondary School and had his medical training at the University of Ghana Medical School. He is the founder of Mindate Service, a mental health service which uses innovation to screen Ghanaians for psychological distress and offer them affordable and accessible mental health care. Mindate has received several recognition which include a profile by BBC Focus on Africa, the Lancet eHealth Journal, and the Social Innovations Journal. Dr. Lati has also participated in some international events, which include the 2019 Social Inclusion in Africa. In 2018, he was the finalist for the famous Students Project for Health competition that was held in Limerick, Ireland. So, ladies and gentlemen, please let's welcome Dr. Lati Dede Achu as he gives us his presentation.
Thank you very much. Good morning once again. Madam Chairperson, the Dean of the School of Public Health, University of Ghana, the Dean of the School of Nursing and Midwifery, University of Ghana, distinguished ladies and gentlemen, I am Dr. Lati Dede Achu, that's the CEO and founder of Minded Mental Health Service. And Minded Mental Health Service is a service which leverages on mobile phone technology to provide affordable and accessible mental health care to Ghanaians. So by way of my presentation outline, I'll take us to the background of mental health in Ghana, the challenges facing mental health care in Ghana, what Minded is doing to solve these challenges, and also the challenges that we've encountered at Minded and how we are maintaining the service and the way forward as well. So as regards the background of mental health care, we're interested to know that the WHO estimates that globally, 1 out of every 4 persons will suffer some diagnosable mental health disorder during the course of their lifetime, and this is quite staggering. Also, it's interesting to know that the psychiatrist to patient ratio in Ghana currently stands at that's 1 psychiatrist to a population of 2 million people. There are currently just 19 psychiatrists, practicing psychiatrists in the public sector, and then the others are actually in the private sector. So what is Minded? What does Minded Ghana do? Like I said, we are a mental health service. We leverage on mobile phone technology to screen the population for mental health disorders, and then we seek to facilitate the provision of affordable and accessible mental health care to them. Now, if you remember from the previous slide, I indicated that Ghana has just 19 psychiatrists in the public sector to serve a population of, 19 psychiatrists, tipping the ratio at 1 psychiatrist to 2 million people. So the Ghana Health Service and the Ministry of Health began an intervention where they thought it prudent to actually provide some nurses and community mental health officers some training in mental health care. So they constructed community mental health units in the various district hospitals, trained these persons and stationed them there to augment the shortfall in the number of psychiatrists that we have. So what Minded does is that we have a toll-free short code or a USSD, which is free on all networks nationwide. It has 4 screening tools on it, which is *844 *55#. When somebody dials the code, the person is asked to follow a text prompt to provide responses to the questions there. After the person provides responses to the questions, we receive the responses and then the person's phone number at our call center. And we have call center personnel who call the people, screen them further, and then help them clinch affordable consultations which are closest to them. Hence, we are trying to tackle the challenges of affordability and accessibility of mental health care in Ghana. So these are the problems we are addressing: poor access to mental health service. Like I indicated, we have just 19 working psychiatrists in the public sector. We have just 5 tertiary psychiatric units, most of which are concentrated in the south, which makes access to mental health care services very challenging for Ghanaians. Also, there's the relatively high cost of mental health services. The tertiary hospitals don't accept the National Health Insurance subscription for the provision of mental health services. It's only the community psychiatric units which actually accepts the NHIS for the provision of mental health services. Also, there's a high level of ignorance about mental health conditions in the country. This is mostly due to the low level of education about those mental health disorders and how mental health disorders manifest. People attribute mental health disorders to having a spiritual background. Hence, there's a high level of ignorance still with mental health conditions as well. There's also stigma associated with the mental health disorders. Like I indicated, people have this spiritual connotation to it. Anybody who manifests or presents with a mental health disorder is seen to be suffering from a spiritual attack. Hence, the person is stigmatized. The stigma consequently impedes against the health-seeking behavior of the person because such people will feel stigmatized against, and then they wouldn't be encouraged to seek some form of therapy or help. So this is basically the setup of Minded Ghana. I began Minded Ghana, that's about 4 years ago when I was in medical school. I brought my colleagues together, friends and family, And we were going to thus combine our skills, whatever skills we had to offer to set up this intervention. I began it in my hostel, medical school hostel. I got some support from the Department of Psychiatry at Kolebu. And 4 years down the line, we've been able to set up a call center facility. It's currently not operating 24/7, but we operate during the day. We have a call center person there who receives the calls and then interviews the patients further and then direct them to where they can get affordable and accessible mental health care. That's our code, *844 *55#. It's toll free on all networks in the country. You dial it, provide responses to the questions which are there, and we receive your responses and our call center via our electronic health database, and then help you get affordable and accessible mental health care. We currently have a nationwide reach as well. So as regards our achievements and impact, we've been able to embark on programs to sensitize tertiary students about those mental health disorders. We partnered with Miss Ghana Universe 2019, and we organized some debates in some tertiary institutions. And also, we are currently the only service provider that provides the toll-free. We are only the entity that provides an entire toll-free mental health helpline in the country. There's currently no existing service that provides an entire toll-free mental helpline in the country. We've also done free psychological screening for over 2,000 Ghanaians over the 4-year period. And we've had some success in clinching about over 200 hospital appointments in the past 2 years. Some of the users were prank users. Some of them declined help as well. Thanks. So how affordable is the innovation? So for our innovation, the minimum requirement is a mobile phone, at least a feature phone, or what we commonly call a YAM. It doesn't require airtime or mobile data to access our screening tool. Our screening tool is a short code. We don't need any airtime. We don't need mobile data as well. You can be in any part of the country and access our screening tool. We also provide free psychological screening. There's currently no service in the country that provides free psychological screening on an ongoing basis. And we also facilitate the provision of satisfied mental health care as community psychiatric clinics. Like I said, we call the clients, screen them further, and then direct them to where they can get affordable health care from. So once again, you just require a mobile handset, no data, no airtime. Okay. Now, as regards scalability of our innovation, that's a 10-year strategic plan. And in 10 years, we aim to convert our call center into one that operates 24/7, and also develop an innovation hub within the call center facility, in which we recruit students and those interested in doing their internship with us to actually develop some interventions to Ghana's burgeoning mental health problems. So this is part of our 10-year strategic plan. As regards scalability of innovation, this is just how we've evolved over the period of years. Logistics-wise, we began with just a handset and a desk in the students' hostel. We've evolved into having our own call center, and we intend to develop it into a mental health innovation hub as well. Staffing, I began with a few medical student volunteers. We currently have some incoming NSS personnel who have an underground background in psychology, who also run our call center in the common run. Public education, we run by word of mouth and social media. We intend to scale up to have frequent events in our tertiary institutions to educate the youth and then raise mental health awareness in our tertiary institutions as well. As regards sustainability, we've realized that funding is a key component of our sustainability. For the past 4 years, we've been running on pro bono services among the management team, as well as contributions from friends and family, and some charitable individuals and organizations as well. We've had the Department of Psychiatry at Kolebu also contribute their quota to helping us fund. We intend to raise more funds through creative ways, through events, and through GoFundMe funding activities. Also, we've realized that the key of our operation actually hinges on volunteerism. So we intend to continuously recruit NSS personnel to man our call center as well. Challenges, funding has been at the top, and the stigma associated with visiting mental health centers as well. We realized that earlier I indicated that we screened over 2,000 people in the past 4 years. However, we've had about only over 200 of them that's visiting community mental health units. We've had people who scored significantly on our scores. yet they decline visiting the mental health units because of the stigma which is associated with them. Staffing as well, we intend to recruit more staff on volunteerism basis and then via the NSS Secretariat. The way forward, we intend to secure sustainable funding methods, like I mentioned earlier, recruit the staff on volunteerism basis, and we also intend incorporating our operations within the framework of the Ghana Mental Health Authority. We also intend organizing more internships for university students, as well as debates and seminars too. So thank you very much. This is what we do. Thank you very much for your audience. I appreciate it.
Thank you very much, Dr. Achu, for the presentation. We would like to slightly alter the program a bit. So we've had our first 3 presentations, and we don't want anybody to forget his or her question. So we would break here and ask a few questions, and then we continue with the final 2. Okay, so the floor is open for questions on the first 3 presentations that we have training in the Ghanaian municipality. The second by Mrs. Caroline Baji on using SMS and VDOT to monitor adherence among women with tuberculosis, TB, and HIV to increase access to mental health screening and management. So please, the floor is open. We take the first set of 3. Yes. Okay.
Adana and one for Caroline. Cervical cancer. So how did you navigate, sir? Especially when you have Christian, Muslim, or other religion, those kind of issues. How did you navigate it? And then for Carol, we all know that HIV, TB are stigmatizing diseases. Some of our people cannot read and write. How did you recruit? And if a woman could not read and write or read the SMS herself, how did you navigate it? Thank you very much.
Thank you very much, Professor Aziato. Yes. Second question.
Okay, so I want to comment to the first and second presenters about ways they intend to scale up the work that was done, because when it comes to cervical cancer, we all know how detrimental it is. And having to train 15 community health officers, how they were able to impact lives. So how do we intend going to other regions of Ghana? And then for the second presenter, use of privacy. How do we intend to reach other people through SMS? Because I work in an organization where we are also into TB and HIV, so we are very passionate about reaching out to people, especially to help clients not to move from first-line treatment to developing multi-drug resistant TB. And also to the third presenter, Dr. Achu, this is the first time I'm hearing about Mind IT. And it's quite an amazing thing that you are doing. How do you intend to reach out to more people? One suggestion I would say is that you can use the other media platforms to be able to reach out. You can have free advertisements in some of the radio and TV stations that we have because of the intention you have. You know, mental health is something that can affect any of us. Like you said in your presentation, 1 out of 4 people happen to develop mental health, but then it's something that we always think is far from us, but it's very close to us. Thank you.
The last question.
Thank you very much. I'd like to congratulate all the presenters. Very insightful presentations made so far. So my first question is to Dr. Adana, and in your presentation, I noticed that there was a 95% agreement between the reviewers and the CHOs, which is quite impressive. However, the 5%, did you investigate to find out the reasons for the disagreement among the 5%? My second question is to Caroline, and I also want to find out if she investigated to find out the cure rates among the intervention and the control group. This would give us a link to the adherence of these clients who were being monitored from their homes. They were not doing dots, but doing some form of CBTC. So if you're able to know the cure rates among these particular groups, it will give us a clear indication for how the adherence went among these groups. Thank you.
Okay, thank you. So we take the next set after the responses. Dr. Adana will start with the responses.
Yeah, thank you for the questions. With regards to how sociocultural issues were navigated, first of all, before the screening program started at the community level, the CHOs went into the communities during the home visits and had health talks with the women. So these health talks were accompanied by, they had charts that had pictures of cervixes in the charts, and showing the normal cervixes that had lesions, and then those that had full-blown cancer. So these were used to sensitize women on the need for having the screening done. So apart from the health talks amongst the women, we also involved the husbands, because many of the women in those communities also need permission from their husbands to go for those kind of screenings. So we also involved the husbands. Then we also had talks with the churches as well. So there were women who even came who had been organized at the church level by their church themselves, like maybe women's group and stuff, and they came in a bus. So having those talks at those different levels really helped. And then when we showed them the charts, they were able to see that the pictures that were taken, it's impossible for anybody to identify the individual that is in that picture. And when the women also came for the screening, any picture that was taken was shown to them for them to approve, that this picture really, really does not tell who you are. If an item of clothing was even caught while the picture was being taken, the nurse had to retake it and ensure that there was nothing that could trace that picture to the individual being screened. So that was some of the things that we did. With regards to... Yes, please.
What did you use to take the picture?
We used the phone.
The CHO's own phone.
We bought phones for the CHOs. Yeah.
And when I go into educated group, you provide refreshments to the participants, CHO's transports to go wherever they are going for the talks.
For the talks, no. The talks are part of the CHO, the job prescription. So they go for home visits. It's part of the chief. So they go for home visits to check blood pressure, to educate women, educate men, educate mothers on how to care for their kids. So we just incorporated the talk about cervical cancer into the health talks that they already give at the community level. There was no extra funding for that, no. No.
Okay. I think you can go on with the other questions.
Okay. So with the scalability, how the CHOs were trained. So the CHOs were taken to Kolebu Teaching Hospital for training. There, the in charge at the reproductive center did the training, and it took 2 weeks for them to be trained. They went in 2 batches. One group of 7 nurses went for the first 2 weeks, and then another group of 8 nurses went for the second 2 weeks. So over that period of time, what they did was they had some theoretical sessions where they learned about cervical cancer, the anatomy of the of the women that they'll be examining. And then they went into practice using the dummy. And after practicing using the dummy, then they also were taught how to do it on the actual clients that come to those centers. So each nurse had the opportunity to do about 3 to 4 clients per day over the 2-week period that they were there. The first set went, and then the second set also went. Okay. So, with the scalability on how to train CHOs if you want to do it, in other parts of the country. So the CHOs that were used were in Ga East Municipal, and they were taken to the centers where they were trained. So I think that these trainings can be done in stages, and the CHOs can go. The purpose of it is to let them get the training and then take it back to the settings where they are already being stationed, where they've been posted. So they can go for trainings at the bigger centers and then take that knowledge with them back to the centers where they are. So the research, what it did was to ensure that there is that constant coordination between the CHOs in the centers where they are with the expert reviewer that they had, so that when they take the pictures of the women that are in their communities, they have feedback that can corroborate what they are seeing on site. So that back and forth not only enforces the learning that they've had, but also builds their confidence and also ensures that the women that they have in the communities don't have to keep going out of the communities that they live in to bigger centers to go and get further evaluation or for treatment if that is not needed. So it cuts down on the cost for the women getting for transportation for one, and then for going for the pap smear, which is a more expensive procedure to go through. And then for the 5% people who had the disagreement, the 5% disagreement rate, yeah. So yes, we investigated why we had that 5% disagreement rate. So apart from some of the pictures where the nurse says, I see precancerous lesions, and the expert reviewer says, no, there is none. There are some pictures that were also of poor quality, because you really have to make sure that you have good lighting to get the lesions that you're looking for. What the nurses do is they use acetic acid and wash the cervix, and then they wait for a minute. At the end of 1 minute, if the patient has precancerous lesions, there will be a white film on the cervix. So it is that white film that they are trying to get a picture of. So when they send that picture to the expert reviewer, it might be that the lighting wasn't positioned properly, and the expert reviewer may feel that what you're calling white is a light reflection. And so that discordance with the expert reviewer, we will see it as a disagreement, since both of them didn't agree that what they're seeing is an aceto-white lesion. So we had that 5% of people being due to them not agreeing on it being really, really a white lesion, or the picture being of poor quality, or the lighting wasn't properly positioned.
Thank you very much. So, Mrs. Baji, could you please be upstanding so that the audience can see you and the cameras can also capture you? All right. So then you can respond to your questions.
Okay. Yeah, I think the first question was on how the illiterate among my participants read their messages. The criteria that was used to recruit them was that even if you didn't have a phone but have regular access to the use of other people's phone, you were included in the study. And for those who had someone who could read the messages for them, they were also included. However, we got a number of them who could only communicate in Twi and Ewe. So with the help of SIHI-Ghana Limited, those who developed the video for us, we were able to record voice messages. So they took the voice messages, and alongside sending the reminder message, the written reminder messages, these women also received the messages in Ewe and Twi every day. That was how we handled those who could not read the English at all. And also, the other one was on how to reach And I must also state that there was something which wasn't part of our objectives. But we discovered that some of the women who were using their husband's phone, when we went for the in-depth interview to find out their reasons for accepting the VDOT or otherwise, we had a few of them, being happy about the fact that their husbands didn't used to care about their treatment. But anytime the husbands received the messages, they cared enough. And one said, even if he is not at home, he will call the next door neighbor to talk to her to take her medicine. And that was something that we didn't set out to do, but we realized that involving other people in their care was also something that others might want to consider. And then how to reach other people with SMS, right? If I got you right, how do I reach other people with SMS? The platform is still there. It is something that you create with a username. It's not so difficult to do. But the challenge is you have to be buying the data continuously and be fueling it so it delivers the messages. And the more people you have, the more you have to pay to deliver and reach them. So we are hoping that when we are able to get stakeholders, tuberculosis is a sensitive issue. There are so many ethical issues to consider. So we will need the support of stakeholders and then go through the due processes before we can expand to other territories. So we are hoping that people like you who are working among them will join forces with us so we can reach as many women as possible. And then the other one was on, did I investigate cure rates? Yes, the main focus of this study was to see how the reminder messages will influence their adherence to treatment. That was our focus. But at the end of it, we were able to get those who were lost to follow up in the intervention and control group. I don't have the figures of head to give you. And then we were also able to see those who completed. But as to testing to know whether they were cured or otherwise, the study didn't go as far as that. Thank you very much.
Thank you very much, Mrs. Baji. Yes, Dr. Achu, please, you can respond to your question on scaling up.
Thank you very much for your question. The first question was how we intend reaching out to more people. And then you raised a concern about the fact that this is actually your first time hearing it. So seeing that it's unethical to screen people and not being able to provide them with care, we actually intend that we'll be able to actually call each and every person who uses our short code. And then that depends on our capacity at every point in time. So we actually don't go on mainstream media now because we have just one person who is making the calls. We went on mainstream media some time ago, about 2 years ago, and we had about 900 people using the code in a particular day. And we had to spend about 2 months calling each and every person. We had about just 2 people using the code. In the coming round, that's in September, we're expecting some 10 NNS personnel. So we intend to actually go on the mainstream media when we get more people to man our call center. Thank you very much.
Thank you. Thank you, Dr. Chu. Thank you very much. So we take the next final set, and then we continue. Please, colleagues online, you can leave your questions in the chat box. We will pick it up and read them as we go on. So the last set of 3 questions, and then we go online and see if we have questions. Yes, please.
Thank you very much for the presentations. I think I'm particularly interested in 2 of the presentations. The first one on cervical cancer. The reason why I'm interested is that WHO has earmarked cervical cancer for elimination. So this is a very interesting innovation. And currently in Ghana, we are rolling out a huge NCDs project. And I think we have some interventions around cervical cancer. So definitely we will follow up and see how best we'll be able to roll out some of these interventions in our implementing districts. see how it goes. My next issue, I'm just curious, I don't know. I know that, of course, you wanted to provide this service at the primary healthcare level, and so, of course, you were using the community health nurses or community health officers, but I'm just curious to find out, did you target any midwives for the training? My second has to do with the mind, what is it called? The mental health intervention. Yes, Mind IT. I just want to find out, how well are you collaborating with the Mental Health Authority? You know, they have a hotline for reporting suicidal tendencies, and I don't know how well you are collaborating with them. And then also, just to find out from you whether you've heard about the Quality Rights Initiative and whether your organization is interested in that project. Thank you.
Thank you. Any other question? Yes, please.
Thank you. Maybe the final and then we'll move on. Yeah, so this one is for Dr. Chu. Dr. Chu, I wanted to find out if you were able to monitor your rates during this COVID period, especially when we heightened in terms of its more like effects on mental health issues. And obviously, from the way you are talking, it seems that you are treading cautiously in terms of scale up because of the numbers that you have. I think that maybe we would want to try to approach this in a different way, because if you have an initiative that is able to address a specific issue, we should be able to make sure that we have the resources so that when people are accessing it, it will be easier. And in that regard, are you thinking about using other dialects and languages so that this service will be more accessible to others as well? Thank you.
Okay. Okay. There is also a question online. So our media crew is putting it online. So it reads, for the mental health project, who pays for you to call back? So Dr. Chu, this is your question. Who pays for you to call back? Or who pays for the patient to send you a message? And what will be the cost or sustainability if many, many more people need your service? So Dr. Chu is on the screens. You can have it. So our final question, Dr. Patricia Kwengu, then you move on.
Thank you so much for the insightful presentations. My question goes to Adana. You mentioned that, before when you were starting, you mentioned that there's a shortage of health workers. So I was wondering, given the burnout and so on, how will this actually affect the sustainability of this project? Because I don't know whether there's any motivation for these health workers or not. And if there's no motivation, how will they be encouraged to continue with this during the scale-up? Thank you.
Thank you. So, Dr. Dan, I think most of the questions went to you. So please, you can start with your responses. If you could be upstanding so the cameras could catch you, please.
Right. Thank you, Dr. Anson. Like you rightly said, we were targeting the community health officers, and so we did not include the midwives in the research. But the reason why we targeted the community health officers was because we wanted to get these nurses, because they're in the CHIS program, and the CHIS program is supposed to be a community-owned program. So because these nurses are already in the communities, known to the community members, that familiarity is there. So, and because the cervical cancer screening is a very private procedure, so having that familiarity with the CHOs encouraged the women to, be more receptive of the idea and accept the services. And then with regards to Dr. Kwengu. Yeah, the motivation, yes, about the motivation for the CHOs. One of the reasons that CHOs feel demotivated in their job is that they don't have some skill sets that they require. And a lot of studies have also shown that trainings and skill acquisition is motivation for CHOs. So as I projected during the presentation, many of the CHOs were very ecstatic to get that training, that skill set. And after the training at Kodebu Teaching Hospital, the confidence that they felt to go back into the community and screen those women in their communities, they were very happy about it. And so they felt motivated to continue to do that service. And even after the study had ended, the CHOs wanted to continue that service, but because we didn't have the expert reviewer retained to continue to do the review for them, we had to put a hold on it at a certain point. So yes, that training that they receive also served as motivation for them to get involved in the program. Thank you.
Okay, thank you. So, Mrs. Baji, please. You didn't have a question? Okay. So, Dr. Chu, please. Who pays for your calls?
Okay. So, who pays for our calls and who pays back for the text messages as well? So, all the costs is borne by our service. We bear the costs for maintaining the short code and then also calling the clients. The clients don't pay anything to us, so we bear all costs across board. Then also the question about how well we are collaborating with Mental Health Authority. Yes, so Mental Health Authority actually knows about us. Mental Health Authority actually has some suicide helplines at a teleconsultation center at Ridge Hospital. We entered an MOU with them last year, and in which we ran that's our short code alongside their service as well. So besides our facility, we also have that set up as the Greater Accra Regional Hospital as well. And about the Quality Rights Initiative, I personally began the training, but I wasn't able to complete it, which I would. And yes, I haven't discussed it extensively with my team, but I believe we would also participate. I'll ask them to also participate in that. Now, about monitoring our rates during the COVID period. Yeah, so COVID came with some challenges. Statistically, we weren't able, or we didn't monitor the rates, but then there was a slight increase in the number of user responses that we got during the COVID period. Consequently, because of the lockdown, we couldn't get many people to visit the community mental health unit, so their consultations had to be virtual. But we haven't really analyzed the rates that is, but then there's a slight increase in the number of user responses that we had. And also about scaling up and then using other dialects and languages. Yes, we've thought about that having those voice prompts instead of text prompts, where, okay, dial this code, dial 1 for 3, dial 2 for ever, dial this and that. We've thought about that, but we actually don't have the expertise to actually do that now. All the services rendered to us comes from in-house, so it depends on the expertise of our in-house team. We are looking forward to doing that so we can reach as many people as possible as well. And about trading cautiously, that's on scaling. Yes, we've initially, when we began, we actually went at full throttle. But like I said, we weren't able to actually reach out to the people who used our code very quickly. When you use our code, we actually have a 24-hour period within which we promise to call you back. Yes, but then when we had too many people using the code, we weren't able to reach them as quickly as possible because we were understaffed. So coming September, should we get our 10 NNS personnel, would actually, should I say, scale up a bit and then increase the rates at which we actually do some publicity. Yes, thank you very much.
Okay, thank you, Dr. Chu. Thank you very much. No, there was a question on the sustainability if many more people.
Yes.
Yes,
okay,
so if you can address that.
Yes, so I missed that. So seeing that all the services are developed in-house pro bono, and seeing that we are offering a service free of charge to the public, we've thought it's very expedient to actually minimize our cost of operations. And we employ some strategies like using NSS personnel to run our call center, NSS personnel who will be paid by the government. There's a program by the Ministry of Business Development where NSS personnel can be posted to your organization for them to work for you. and after which they will be paid by the government. So we're actually riding on that to actually recruit our call center personnel. We try as much as to thus reduce our operational costs. However, some of them are actually fixed. At the moment, we have a budget of about 25,000 cedis, and that's running the service for a year, which we've been doing for the past 4 years. We intend to launch more funding campaigns to raise more funds for the service as well. That's what we seek to do.
Thank you very much, Dr. Chu. Please, a round of applause for our innovators, and thank you very much for your questions. So we quickly dive into the last two, which will be by Mr. Samuel Maiden, and he's presenting on community scorecard to improve accountability and governance of community-based health planning and services strategy. So Mr. Maiden is a public health scientist and a researcher with the Ghana Health Service. He has a background in community health nursing and psychology and holds a master's degree in international health from Heidelberg University in Germany and a Bachelor of Arts in psychology with sociology from the University of Ghana. His research interest spans the area of health systems, community engagement, patient feedback, service delivery, and adolescent health. Please, with a round of applause, let's welcome Mr. Samuel Maiden.
Thank you very much for the opportunity to share experience on the implementation of community scorecard as a part of social innovation in Ghana. And so, Prof. Chair, senior colleagues who are also participating virtually, fellow innovators, ladies and gentlemen. Like you said, my name is Samuel Maeden. I work with the Ghana Health Service. We'll take ourselves through, or go through the community scorecard. Using a community scorecard to improve accountability and governance of the community-based health planning and services. Next slide. Okay, so Ghana's primary health care system is operated in a three-tier system, especially at the primary care level. We have the district, the sub-district, and then the community systems. Now, the districts basically comprise of what we call the district health management team, and that has the DHD and then the district hospital. Their main responsibility is to have a technical coordination operation in terms of planning, monitoring, and service delivery at the primary level. The sub-district level has the health center and basically operationalize the plan activities by the district's health directorate. And then in the community level, we have the community-based health management, community-based health planning and services. Their main responsibility of operating this, the health staff jointly work with community leaders and households to deliver essential health services at the doorsteps within the household level. Next slide. Okay, so basically, the CHIPS provides a health system strategy that organizes service delivery at the periphery within the context of a well-defined formal health system through a community support system. So how was the community scorecard introduced into Ghana's existing health system or structures? In January 2018, Ghana Health Service, together with the Ministry of Health, had an experience tour in Ethiopia, and where Ethiopia was implementing a community scorecard. So it was a field tour to have an experience of how the implementation goes. Now, Ghana integrated the innovation based on the experiences, observation from the field in Ethiopia into its primary health care settings. Now, after the study, the key thing here is that we had a structure, similar structure that, looks same within as Ethiopia. And so we're ready to integrate. So at a stakeholders meeting and a discussion of how the community scorecard operates within Ethiopia, stakeholders agree that the community scorecard, its implementation should be embedded within the CHIPS strategy. And so within CHIPS strategy, one of the functional things that you need to consider is to have community health management committee, which is the governance structure embedded within the CHIPS. You can't have any functional CHIPS without the Community Health Management Committee. Now, the functions of the Community Health Management Committee is to actually link between household and the formal health system, and also to mobilize resources within the CHIPS zone, engage internal and external stakeholders to mobilize resources to support service delivery, and also monitor activities of the community health officer and then a volunteer, and then support policy directives at the community level. So, what is the community scorecard? It's a participatory and action tool implemented through a community-led process that leverage on community existence governance structures within a defined primary health care system to promote social accountability and responsiveness to the needs of clients in service provision. Now, the CSC, when I say CSC is community scorecard, process involves two components. It involves the scoring session and action plan development. And in the scoring, the CHMC members comprise of community leaders, basically who represent this voice of the people. And so to be able to implement this, they convene, meetings to conduct the assessment and have discussion on those, the tool that is given to them. We'll quickly look at the various indicators that they discuss on during the community meetings to be able to assess the health systems as a governance wing. So these are the 9 primary quality of care indicators. When we say primary quality of care indicators, these are basic quality of care indicators teased out of the implementation strategy in terms of quality of care domain. 1, we look at caring, respectful, and compassionate care. 2, we look at waiting time for service provisions at the time of entry. 3, we look at availability of medicines, diagnostic services, and supply. 4, they also look at availability, accessibility, and quality of care, quality of services and infrastructure. They also look at cleanliness and safety of the facility. They also look at leadership and management of the facility. The 7th one also looked at home visits by the CHO or the CHN or the midwife. And then the 8th one looked at the conduct of a home visit by the community health volunteer. And the 9th one assesses the health insurance accessibility or availability within the health system. So each of these indicators is given a weight of 1 to 3. 1 means bad, 2 means average, 3 means good. Now, the communities develop a community health action plan out of the scoring. And so when they have a lower score, those lower score are basically a gap, and they assign reasons to scoring, caring, respectful care. They assign reasons to why the caring is not good or why there is no medicine available. And so those reasons are documented. And after the score, it is entered into the district health information management system. And quarterly, we populate this from the DIMS 2 into a web platform. And you see the yellow, green, red, the color coded. The red is aligned to 1, and yellow is also assigned to 2, and 3 is assigned to green. which means that within the interface where you are seeing the color coding, it is showing the performance of service delivery as a patient feedback within the health system. And this is populated quarterly on a web platform that everybody can view. Next. So the quarterly process of the community scoring, like I said in the previous slide, the first one, the CHMC conduct a tour to the facility to have a feeling, first-hand experience, or an experience, physical experience of how the facility, the washrooms are, how wires, are displayed and all that. The second one is to sit down to do the scoring through a voting, and majority decision within the discussion is carried and documented. And so the third one also is to develop an action plan, and this action plan to address problems identified in the scoring process. And progress of action plan from the previous quarter, when they meet, are discussed, how the implementation went. And then the fourth one, there is also an interface meeting held between the facility head and the leadership of the CHMC. Because that time they discussed how to resolve some of the issues that they were able to find during the scoring and assessment process. And then the fifth one, they enter this core into the district health information management system. So they keep copy because they don't have direct access to the district health management information system. For the sake of accountability, they keep copy and give copy to the district health information officer to enter into the DIMS. But when it is populated, they have access to the web platform where it is displayed in the color code that was displayed. So it's actually a bottom-up approach process where we take community feedback into a national platform, so you can see the Director General can view the community's response within that quarter and be able to take an action when there is no a low score on an indicator in terms of caring, respectful care, or medication availability. So these are few examples in terms of learning from some of the achievements that the community scorecard has been able to do within the implementation when we roll out the tool. So it has actually improved resource mobilization. And in Ashanti region, for instance, the CSA assessment found that the maternity section was in a poor condition. And in consultation with the chief and elders, household were levied and resource mobilized to renovate the facility. Now, in Western region, in Upon Valley's chips, the CHMC purchased a Doppler to enhance quality of AN services. I mean, these are all quality of care where community contribute to provide some of these fewer logistics for a midwife to be able to enhance service delivery. It has also strengthened accountability. Now, in Upper West region, the CHMC ensured that a midwife was posted to the health center through the revelation that there was no midwife, but then there was also a need for this service of the midwife at the health center. In Wambong and the Savannah region, the CHMC also found a frequent shortage of medicine. And so the CHMC wrote to the district health director to be able to respond to their needs in terms of medication availability. And within a week, that response actually proved positive. So you see that down there are the actions. So if they say they want to write a letter to the district director, they put in those actions in the system. And when they meet and review those actions, the implementation is tracked. So that is also color-coded in terms of the progress of the implementation. Unlike previously, when you have a community of action plan, you don't really see the progress of implementation unless you go to the field. But this, you can log into it and then monitor the implementation of the community actions to address health system gap. Next. Okay. So, what are the steps to further sustain the community scorecard initiative in Ghana? Now, we actually having a plan to engage regions to develop a sustainability measure. We recently submitted a grant to the French 5% to have this embedded when we actually get the grant approved. That's why I was silenced on it. It's an application we submitted. Now, to also strengthen integrated use of the community scorecard with other scorecards. There are other scorecards on the platform. We call it the other two scorecards currently: reproductive, maternal, newborn, and child health indicators. And these are indicators used through our routine system. And we also have the malaria scorecard. And so these data, when the community meets, we want to see how the community use the data in terms of target coverage, that the area within the zone is targeted to achieve a particular indicator. If they are not achieving, we want to use this platform, the community scorecard, through the CHMC meetings to discuss why the district is actually not achieving its targets and have addressed, have solutions to this. Because some of the things are actually community involvement. And if mothers are not coming to the clinic, it's the responsibility of some of the household to actually talk to their wife, their children, or whoever is sick there to be able to come to the clinic. And secondly, we also want to integrate the community scorecard as part of our planning process within the service. What we have learned some lessons here, that the district assembly has what we call, implement what we call the public financial management accountability template as part of the social accountability system, if you have heard of it. And the social accountability, there should be a feedback from the health directorates inputted into their plans and budget. But oftentimes when you see the disassembly scores, the league table, you see community involvement is very low. And so we're able to talk to or engage UNICEF and have a proposal approved. And they granted us some funding to do a framework that's in order to operationalize the community feedback with as part of the inputs into the template. So there is work ongoing on that way, on that as well, which is, I mean, if you're able to do this as part of social accountability for a country, we'll make a positive progress out of it. Now, WHO recently, so community scorecard is also embedded in the WHO, one of their implementation strategy called Maternal and Child Health Community of Practice. And in this, we had some discussion with them to do a costing analysis of community contribution. Because for any health system, you also need to understand what the community contributes towards the service delivery. And so we're planning a study around it, and we're having continuous discussion with them, and we hope that by the end of the year, we'll be able to commission this as part of our health system improvement strategy. So, we'll watch 3 minutes video, and then we end.
Community quality of health services in their CHIPS zone, and importantly, the development of community health action plans (CHAPS) to address the issues identified during scoring sessions. Every CHIPS zone is supported by a group of 7 to 13 community leader volunteers known as the Community Health Management Committee. Accra region, the situation was the same at the Tema General Hospital. Through community scorecard, inadequate lighting systems, and water problems have been solved.
Through this, we wrote a letter to the Metro Assembly and then met the presiding member, and then an NGO which also came to our aid. So through the stakeholder engagement, we had a Madia Foundation to donate a polytank, around 2,000 size polytank to help address the water issues at the National Hospital. Through the stakeholder engagement also, we got Assembly to get the ECG to help us fix the street lights, which are working now. So work is in progress. I'm very happy that the community's involvement has been able to make a positive line to the hospital. So the community involvement is very, very, very vital. And work is ongoing, and we hope to do some more.
Okay, thank you very much.
Another round of applause for Samuel. Samuel, thank you very much. Thank you. Okay, so we go on to our final presentation, which is on community engagement strategy to sensitize and screen people on hepatitis B. This will also be done by Mr. Wisdom Apusiga. So Mr. Wisdom is an award-winning nurse in the Upper East region in 2020, and he's also a strong health advocate. He had his secondary education in the Bolgatanga Senior High School in the Upper East and proceeded to nursing training college Bolgatanga, and also has a diploma in registered general nursing. So Mr. Apusiga Wisdom since has been at post at Sandema Hospital until 2016, when he had study leave to study at the School of Nursing and Midwifery, University of Ghana, where he's pursuing a BSc in nursing with pediatric option. He graduated in 2019 with a first-class honors and has since been at post and currently working at the Sandema Hospital. So, ladies and gentlemen, please let's welcome Mr. Wisdom Apusiga.
Good afternoon, and thank you for this opportunity. So I'm here representing Impact Mission Ghana, and our aim is to combat viral hepatitis in, especially B and C in Upper East region. Okay, so the background, 250 million people were estimated to be living with viral hepatitis as of 2015. And then, according to WHO, they said that about 2 billion of the world's population have been exposed to viral Hep B. And then the prevalence of Hep B is greater or equals to 8%, whilst that of Hep C is around 5 to 10%. There's a research conducted by Abesik, and he also came out, he found out that the prevalence among preschoolers was 0.55%, whilst that of adolescents was 14.3%. And in adults, it was 8.36%. And among blood donors, it was 7.7%. So in 2018, Impact Mission Ghana emerged in Upper East region to respond to this worrying statistics. So our main aim is to reduce stigma, early detection and then early detection and prevention of complications, bridging knowledge gap, and then infection prevention of viral hepatitis B. Okay, so with the reducing stigma, our main scope is to do community engagement. And then through that, we try to let them understand that Hep B is a vaccine preventable disease. So if one person is having in your family, you can easily vaccinate the rest. And so that has really, like they've actually bought into it. And because we go into the communities, we're able to gather all of them and talk to them. So once we test positive, we just vaccinate the rest. And so the chain is broken. Okay, so early detection too, we do free screening. All our screenings are free. We don't take any amount of money. And then with a bridging knowledge gap, aside the community engagement, we do lots of radio education. And then prevention of mother-to-child transmission of Hep B too. We've also done a lot of work there. That is, try to educate nurses and midwives that the Hep B vaccine alone offers about 70% protection. So in case a positive mother can't afford the immunoglobulin, they should give the vaccine alone at birth. Because per the policy, per the child welfare booklet, Hep B vaccine was supposed to be a birth dose vaccine, but this hasn't been implemented. So we also have our social media handle where we do short videos, and then we do certain write-ups too as well. We organized a quiz competition that was in 2019 for a senior high school. That was Zwarengo Senior High School. And about 1,200 to 2,000 students were in attendance. And with the infection prevention, we do subsidize or free vaccination, depending on the situation. So our vaccination ranges from 5 Ghana cedi to 10 cedi per injection. So achievement or impact of so far we've covered 4 districts out of 15 municipal stroke districts in the region. And then we've engaged in over 35 communities. And we've also done over 4,000 free screening. And our vaccination rate is 70 to 100%. In one of our communities, we screened 742 of them. And that committee, we're doing it together with HIV. And one person tested positive for HIV, but when it came to Hep B, 75 tested positive. And all the negatives, we were able to vaccinate them because the vaccine went for 5 Ghana cedi, so everybody was willing to vaccinate. And early detection, we have over 300 positive cases so far, whom we've canceled, and some of them we call them from time to time just to check up on them. And some we've lost to follow up. Earlier this year, I was in a ward when a 2-year-old child came and died, and the child wasn't having insurance. So when I interviewed the mother, it showed that she delayed at home because they were not having insurance. So by the time the child came to our facility, the child's HB was 1.1. And in no time, the child died. So I started an appeal for funds just to also identify such children who may also be suffering like this girl. And we're able to offer access to health to 241 children just this year. Okay. So in terms of affordability, our program is very affordable because of the kind of team we have. Every team member is really very dedicated, and we don't pay anybody. Mostly, we can travel like 2 hours to go and do the screening, and nobody takes anything. All we do is that we get fuel for you for your motorbike. And that usually costs about 20 Ghana cedi on hand, at most, at least, sorry. Then to the beneficiaries, because the screening is free, they usually embrace it. For instance, if we've gone to a community and about 700 people within 6 days have been screened, and out of it, about 600 people have taken the vaccination. That should tell you how cheap it is to them. And also, we move to them, so they wouldn't have to travel, because most of them are usually at the hard-to-reach areas. So because they are far away, if you tell them to come to the towns and have it, they may not come. But because we move to them, and they also follow up to do the second and third is actually affordable. Our main challenge is the logistics. Because we do the vaccination, because much of our fund comes from the subsidized distance vaccination, which is usually about 5 to 10 cedi. So if you vaccinate about 10 people, we get about 30 cedi profit on top. That is what we get, because the vial goes for 70 Ghana. And out of the 30 Ghana cedi, that's where we feed from. That's where we buy our fuel, like for the rounds. And then we still use that to buy the test strips in order to still do the free screening. So, per the affordability, our main challenge is the logistics. Scalability, already we started in Busa North District, our first screening, and we have done it in 3 other districts in the region. We actually wish that we could cover everywhere in the region, and possibly extend it. And then when we were in school here, the program actually started here, but by then we were not in a group. We were going around talking to people about viral hepatitis and still doing the free screening. So we did it in parts of Accra, on campus, and then I again traveled to Central Region to spend some days there to help some other people screen and take the vaccine. Okay, so our program is very sustainable because of our team members, very dedicated team. And we also get support from opinion leaders. Mostly if you go to the chiefs, they actually open up and allow us to do the screening and then embark on the awareness too as well. We actually wish that if we get more funding, we'll do more. So our main challenge is that we don't have any specific source of external funding. So like I said, now we are relying on proceeds from the 30 Ghana cedi proceeds to do all that. And then we'll also engage in like partnerships. So we'll tell you, buy the things, and then we'll come and do the screening free of, like, we'll come and screen, we are not charging you anything. So we'll be the personnel doing the screening. And then we also wrote for support from one politician some time ago. And he sponsored 1,000 screenings. So that was our last major screening. Yes, and when it comes to the vaccine, ideally everyone who has taken the vaccine is supposed to check the titer to know whether the vaccine is really working. But most of all those who vaccinated will not be able to check their titer to know whether the vaccine has really worked. I checked mine, and I have over 836 antibodies quantitatively. And in terms of the laboratory services to Upper East, there's no lab in Upper East that does viral load and also do the titer. So most of those labs are sourced at Tamale, and some of them are also expensive to them. So way forward, we wish we could get external funding, and if we get external funding, it means that we are going to also train some of our colleagues, especially health workers, and also do more screening do more screening and vaccination. And we are also hoping that they will implement the BEV dose Hep B vaccine. My first slide, you realize that the prevalence among preschoolers was 0.5%. Meanwhile, Hep B vaccine was introduced in Penta 2002, January. So if it has been introduced, why are we still having 0.5%? And even if you look at the figure for the adolescent, which was 14.3%, it's still very high because Penta was introduced in 2002. So why do we still have that? So there's a lot of work to do there. We also hope that we'll test the efficacy of our program to know whether people are really, the vaccines we are giving, they are really producing antibodies or not. And then in the long term, we hope to have a viral hepatitis laboratory in Upper East region where people can source all these tests in the region. Okay, thank you very much.
Thank you very much, Wisdom. Please, a round of applause for all our innovators. Thank you so much. I would like to acknowledge our colleagues online. We have Dr. Elizabeth Alhassan. Thank you for joining. We have Anna Gerling Hernandez Bonilla of SIHI and TDR. Thank you for joining. We have Jen Basina. Thank you for joining. And then Diego Duque of Alma. Also, thank you for joining. And then Phyllis Awo. Thank you also very much for joining. So, ladies and gentlemen, it's time for our questions for the last two presenters. We take the first batch of questions for the last two presenters, please. If you have a question, you just raise your hand. I'll come to you. Okay.
Thank you very much for the wonderful presentations. My first question goes to Mr. Mayhem. I want to find out if communities were involved in the questions that, or maybe the indicators that were included in the scorecard. Their inputs were sought in terms of including that. And also as to whether their perceptions or views regarding the services being provided are marred or influenced by partisan politics when you went out there to the field. My next question to Mr. Apusiga, I wanted to find out from you if in your work with them you do follow up. You experience that you have identified that there's stigma among them in terms of people experiencing that. And then when you do the follow-up, then everybody in the community knows that there's somebody with this in this family, and then how do they react to that? Thank you.
Thank you, Madam Chairperson. The next question.
Thank you. Many times to the presenters, I see the passion with which Samuel was presenting the scorecard, and I want to commend Wisdom for the dedication to duty. My question goes to Samuel. With experience with the use of scorecard years back with Ghana Health Service, what I really realize is that it's very effective at the rural and peri-urban areas. So I was happy when you showed in the video that Tema has been able to use the scorecard and then they've had some benefits from it. What are the strategies that you use in getting people in Tema to participate actively to be able to reach where you got into? And what are the ways that you intend to ensure that the use of scorecard is also effective in urban centers?
Any other question? Yes, please.
Thank you very much for the presentation. My question goes to Samuel. I was when you were doing the presentation, you made mention of the fact that when it is done, the challenges are itemized and then interventions are made. My question is, you realize that some of them will be beyond the community members and then the opinion leaders. So when it is beyond them, how prompt is the response? And is there any political influence with regards to how the interventions would be done? Thank you.
Thank you very much for these insightful presentations. My first question goes to Sam. I want to find out, is it the community members who themselves enter the data into the DIMS? And if not, is there always, how are they able to verify that what has been entered is really what they discuss? That's one. Okay, and then for Wisdom, I wanted to find out, as part of the education, do you really tell the participants that they need to check their titles so that if those who can afford could still go ahead and do that? Thank you.
Thank you very much. Dr. Opoku-Mensah, did you have a question? All right, so we'll take the first round. So Samuel, you can answer, please.
Okay, thank you very much for the question. So how did we get the community's perspective and contribute to the indicators that were selected? And so when we came back from Ethiopia, we had a community, like a stakeholder forum, where some of the CHMC, where they actually play a very active role in contributing to our service delivery, were part of the discussions in selecting the indicators, in agreeing on indicators. These indicators actually is embedded in the quality of care domain. So if you see all the things, they are agreed or acceptable quality of care indicators. And so when we had that discussion, one of the inputs, which was also very critical, was the availability of health insurance. In Ethiopia, it wasn't part, health insurance assessment wasn't part. So the community members said, because oftentimes when they even have the card, they are not able to access in terms of the facility is not accredited, so they don't get access to the services within their environment. So we should add, so that very input was one of the proposals from the community members during the community stakeholder engagement to agree on it. Okay, thank you. So in terms of the perspective and influence by politicians, we have got to that level where you cannot do without it. But what we actually set out was that during the training, we put service delivery at a point where with politics, irrespective of your status, you need care. And so when it comes to that, during the discussion, you saw in the video how the community leader or the secretary was leading the discussion. So we discussed service delivery so that our mothers can have access to what are the challenges facing us. As for our big men, it's agreed that, we'll sit in Accra and all that, but within our environment, how are we able to improve our service delivery? Let's discuss, and then they'll score on. So irrespective of the political affiliation, those things during the training, the orientation before the scoring, it is discussed. That's why we always want the community to lead the discussion. And we set out a criteria that no health staff should be part of the discussion when they are deliberating on the indicator. Until they are done, then they come back to the health facility leader and have a one-on-one interaction on the gaps that they found. Okay. The urban influence. How best we can improve the urban setting in terms of the community engagement. That's one of the interesting things that I actually found. We found when we rolled it out in Greater Accra. In Ga East, we also did something. So when you were doing the presentation, I was reflecting on in Musuku, one of the communities. I mean, in the urban setting, sometimes we assume that the community engagement is not possible. Here, you will always find a lot of even retired people, engineers, doctors, nurses, who are passionate to contribute to some of the service delivery or the discussion. And that is one of the things when I involve myself in the urban setting, I actually realize. Some are retired teachers, headmistress. In Tema General Hospital, one of the women, and she was a diabetic, and she was actually commending us for coming out with some of these things, and that they are ready to even support where there are no even BP apparatus, because she should be able to wake up in the morning and go to the nearby CHIPS compound and check the glucose level and check the BP. And if those things are not there, how can we do? Then they can mobilize resources and have it available there. So these are some of the things that actually came out. So doing community engagement in the urban setting is possible, but we need the right people to engage through the right process. That's one of the things we always have to look at. And so beyond the action, that's solvable within the community. That's one of the things. So you saw the bottom-up approach diagram. At the top, which is not part of the 5 steps, we put in the high-level leadership. And as I speak, we have made some investment for the minister to go out and then have experience with the CHMC and have some discussion with them. It's one of the advocacy things that we are doing behind. And it's true, some of the things is beyond the community. Some of the things are even beyond the health directorate. So bringing in the disassembly, bringing in the health minister is one of the things we are doing behind the scene to get it resolved, especially the NHI issue and medication and availability. Okay. So I will encourage, researchers around the community, they document reasons on the, and that one we don't actually write it in the system. It is kept with them. There are reasons for scoring A, B, C. It's one of the interesting areas that we can always even encourage students to go and collate and see how we analyze some of these reasons, and document it and share during such innovations so that we can tailor it, engage the policymakers to see how we get it resolved. Data entry, yes, they keep copy. They always produce two forms after the scoring. So they keep one with them and give one to the community leaders don't have access to the DIMS. But for the scorecard platform, they are registered. They have access to it. So after populating it, they see the red, yellow, green. So they compare. They go back and compare whether what they said, it really reflects they are red or yellow or green in terms of the score outcome. Okay. Thank you very much.
Thank you, Samuel. Thank you. Wisdom, please, you can respond to the question.
Okay, so with regards to the follow-ups and stigma, we actually do follow-ups by way of phone calls. And with the stigma, we actually haven't encountered any because of how we do the counseling before. And yes, so we haven't actually encountered any. In fact, one of our screening, after telling somebody was positive, he was so excited that he took his motorbike and was bringing his family members to also come and screen. So he did that the whole day. He was just bringing people, come and screen. When you screen, tell them, I was positive, so take it so that they also get. He was just telling us that way. And so with the stigma, we're actually making great strides there. And with the titer, we tell them to check. We actually tell them because when we first started, most of those who were vaccinating around that time, some were using ice chest, food flask as their vaccine carrier. Some to just put pure water and dip the vaccine inside and be going around vaccinating. Some to just put blocks around and be vaccinating. So all these things can actually compromise the quality of the vaccine. And we've actually encountered a lot of people who have completed their vaccination. They took the 3. When you test and they are positive, they say, but I completed the vaccination. So how come I'm positive? And so we actually encourage them that they should check their titer to be sure that they are well positioned. Okay, so thank you.
Thank you. Thank you. Thank you, Wisdom. Thank you. Okay, so if there are further questions, our colleagues online, please, you can also post your questions in the chat box. If there is a question, please, our media crew, can you pull it up if there's a question online? Okay, back to the auditorium, please. Any other question for Samuel and Wisdom? Okay. Is there a question in the chat box online? No, thank you very much. Okay, so then please, with a round of applause, let's give a big thank you to all our innovators, Dr. Adana Nwamene, Mrs. Caroline Baji, Dr. Latte Achu, Mr. Samuel Maiding, and Mr. Wisdom Apusiga. Thank you very much for your wonderful insights into the innovations you have shared with us. So we've come to the end of our presentations. We now call back our chairperson to the high table to give her closing remarks for the program. So please help me welcome Professor Mavis Dakojeke as she comes to the high table to give her closing remarks. Okay.
We started in the morning, but we are in the afternoon, so I say good afternoon to everybody, and thank you for being part of this wonderful occasion, joining me to see to the end of this program. And since we started, we realized that we are in the right place and learning a lot of things going on, as I shared initially, that when you talk about social innovations in health initiatives, it couldn't have come at any time than this time that COVID-19 is everywhere, that everybody is trying to be kind of careful, and then you are careful about what? You are careful about what is going on around you. So our social environment is very important in terms of the decisions, our attitudes, and our behaviors in society. So that is very important that we have to look at. And we heard from the Dean of School of Social Sciences talking about the fact that, Dean of School of Public Health, talking about the fact that since their inception, they have been innovative, going out there to do different kinds of work out there to benefit society. We also heard from the Dean of Nursing and Midwifery talking about the fact that we should also try to find spaces to engage in research that is related to health, because those are issues that affect us day in and day out. So when we also kind of look at the presentations that came all the way from cervical cancer, we heard about tuberculosis, mental health, governance issues, and we also heard about community engagement when it comes to hepatitis B and C. These are issues that are with us on a daily basis. And then when you think about everything that we heard, it's more about giving ownership to the people to own whatever goes on. And once you give it to them, you are assured of commitment. You are also assured of participation from the angle of the people. So then people know that they have health issues, but then how do they handle those health issues among themselves as people come in to support them? So those are things that are very, very important that we have all learned from in terms of taking those bold steps at the community level, and also not just from one angle where people are giving it to us, but then our own behaviors and attitudes in terms of those things that we receive from people. So then when we talk about social, we are going to the community, our way of living, what are some of the issues that affect us in terms of our health, and also how innovative can we be so that we are not doing the same thing all the time. We all heard about innovative ways that people, and creative ways that people are coming out with things, and they are taking the initiatives to put it out there. Yes, they have challenges, but then these challenges are not challenges that they cannot do anything about. They are challenges that you and I can also support to address. So as we go home, let's take that with us, that these are the challenges they have identified. Those who did researches and they talked about the fact that there were areas that they couldn't cover, they also open up windows for those of us who are engaged in research to identify those areas, to go out there and work in those areas. So there are opportunities for us to tap into to do things for ourselves. So looking at everything that we have done here today, what I'm thinking about in terms of the vision and mission of SIHI is the fact that they want to take a very holistic approach and also bring healthcare to the doorsteps of people, where everybody takes ownership of it and say that, how can I contribute in bringing this thing or bringing that thing? And one thing I want also the innovators to take with them is that some of the challenges that they have are challenges that one innovation can address another person's challenges. So then you are thinking about people taking photographs, and also people also using their cell phones. One person is doing this, one person is doing that. So if my challenge is something that you are addressing already, how can I learn from yours? So much as we are listening to you, I think the innovators could also look at what they are doing out there, great jobs that you are doing that we could all learn from and try to support each other, because all these are challenges within the communities. You find cervical cancer there, mental health there, governance issues are within the communities, hepatitis B, all those issues are within the communities. But then also another thing we want to say is that we are not in normal times. And when we think about the COVID-19 didn't come and then no more cervical cancer, COVID-19 no more hepatitis B, COVID-19 no more mental health. It came and these issues are being escalated. So if they are being escalated, the only way we can address these issues is just being innovative. We might not get it all, but we are striving to get to that point. So that is where we all come on board to ensure that at the end of the day, we have a better place to live. And then it's within our local community, but we are also projecting ourselves globally in terms of trying to achieve our sustainable development goals in terms of Ghana, striving to get there. So I would say that as you live here, you want to come together to kind of come up with something like communities of knowledge or communities of innovators, and then you work together, and you might be addressing issues side and side because you might be doing something that another person might learn from, and you could also bring other people on board. And I think also those who are the coordinators of SIHI, they have also realized that you have a lot of challenges, you need more funding, you want to scale up, so they will work with you to ensure that you are able to scale up, because if you have gotten to that point and you are left hanging, what is the next step? So then you tap into other resources, and also I think they will also come on board to support you equally. So I say thank you very much for being here today, supporting me, and getting it to where it has been today. I have learned, and I hope that you have also learned something from the presentations. I say thank you very much to those who gave us the opportunity to come, and also I'll say very big thank you to the innovators. Yes, you have been very, very innovative, because we are not in normal times. Thank you, and have a good afternoon.
Thank you very much, Madam Chairperson, for the closing remarks. Ladies and gentlemen, a few announcements, and then we leave. So we have lunch packed out there. So as you get out, please do not forget to pick your lunch. We are very grateful to everybody for coming to this launch and dissemination workshop. To our colleagues online, we thank you. To the project team, thank you for wonderful organization and bringing these innovators together to be able to help solve problems of the country. We are very grateful also to funders and everybody who has been able to make this possible. To the media, we thank you for your time. We pray you give this a lot of coverage as much as possible so that the information gets out there. To everybody who is here, we are grateful for your time and we thank you. We hope to see you another time when we put this together again, and God willing, it will be soon. Thank you all very much and do have a good day. And thank you again for coming. All right.